Welcome to this special episode of Diabetes Core Update, where we are going to discuss oral health and diabetes. I'm your host, Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. As I said on our first podcast of this oral health series, oral health is an underappreciated topic among medical professionals, and it is a topic that is of critical importance to our patients. You can ask any patient and they will let you know that, and we are beginning to learn why it should be important to us as well. These two special editions of Diabetes Core Updates focused on oral health are sponsored by Haleon, the maker of Periodontics. Let me share a word from Haleon. Patients with type 2 diabetes are more likely to have gum disease, cavities, and other oral health problems. Periodontics is a daily use toothpaste that is clinically proven with twice daily brushing to reverse and prevent gingivitis, an early form of gum disease. Visit HaleonHealthPartner.com to learn more about the Periodontics portfolio of oral health products and how they can support your patient's gum health. Now back to our podcast. Joining me to discuss this important topic, we are privileged to have Dr. Wenche Borgnakke. Dr. Borgnakke, DDS, MPH, PhD, is an adjunct clinical assistant professor of dentistry in the Department of Periodontics and Oral Medicine at the University of Michigan School of Dentistry. She approaches this topic from the perspective of both dentistry and public health, and I can tell you something that you will get a sense of very quickly is how passionate she is about this topic. Dr. Borgnakke has published well over 100 articles in the dental literature. That's how I became aware of her when I was looking who we could bring in to speak on this topic. On a quick Google search, it became apparent. And one of her areas of interest is the relationship between oral health, diabetes, and blood sugar control. Welcome, Wenche.
Many thanks for having me, Neil. It's such a huge honor and pleasure for me to be with you.
Wenche, I want to thank you for sending me a bunch of updated references by email. It's clear there is a lot going on in the field, and that reflects the importance of oral health and systemic disease. We're covering this topic because there is so much to cover over the course of 2 podcasts. In our last podcast, we discussed the different types of periodontal disease, as well as both oral and dental consequences of having periodontal disease. And today, in our second oral health podcast, we're going to cover practical recommendations that we as clinicians can use to help patients address oral health. But before we jump into today's topic, can you remind us of some of the most important learning points from the first podcast?
Well, absolutely. Diabetes and periodontitis share common risk factors, so they often occur simultaneously in the same patients. But additionally, there is strong scientific evidence for causal two-way adverse effects between diabetes and oral health. Hyperglycemia adversely affects the oral cavity, especially the periodontium, that consists of the soft and hard tissue surrounding the teeth. People with diabetes experience more prevalent and earlier onset and more severe periodontitis than their normal glycemic counterparts. Diabetes patients have actually lost many more teeth than those without diabetes, I'd like to add. That is, periodontitis increases the level of glycated hemoglobin through bacteremia and its elicited inflammatory biomarkers, and thereby contributes to incident type 2 diabetes, gestational diabetes, and diabetes complications such as cardiovascular disease, retinopathy, and nephropathy. People suffering from periodontitis are much more likely to also have diabetes than those with healthy periodontal tissues. If left untreated, severely periodontally diseased teeth will eventually loosen and be lost, with all the negative consequences such as pain and difficulty biting and chewing the healthful food they are advised to eat, as well as decreased self-esteem and poorer quality of life overall. The good news is that periodontal treatment, also known as deep cleaning, that can be provided in general dental offices or clinics by dentists or dental hygienists, can lower glycated hemoglobin level by a half percentage points, which is in the order of magnitude that can be expected from adding a second oral diabetic medication to metformin. I would like to add a result from my own clinical research, namely that extracting all teeth that are severely affected by periodontitis can decrease the glycated hemoglobin by 1 full percentage point without any other changes in the person's diet or behavior, except for the extraction of all the diseased teeth.
It really is amazing, Wenche, and thanks for going over that, because I don't think that most of us appreciate it. And if there's one big learning point that I'd really urge our listeners to take away, it's that if someone is having difficult to control blood sugars, if they have diabetes and their blood sugars on appropriate treatment are difficult to control, think about the teeth. Have them see a dentist, because your point about getting as much bang for your buck by seeing a dentist and that drop in A1C of 0.5% being similar to what we get when we add another oral agent is critically important for us to understand. And I know we all have lots of patients who we struggle with to get things in good control. Now, jumping on into our core topic for today, what are your recommendations for what we should do as clinicians, primary care and endocrinology, to help our patients achieve optimal oral health?
First of all, you should strongly encourage your patients to take good care of your teeth and gums. But it takes some explanation, and you'd have to tell them a little of what we have gone over, and to illustrate that good oral health is so important for managing their diabetes, and also, very importantly, all its complications that can be adversely affected by very poor oral health status. It's very important to see a dentist, preferably regularly, but at least one time once you get the idea of the oral health, because most patients will have buildup of plaque and what's called tartar, which is the calculus, which is the mineralized soft deposits that are accumulating on the teeth along the gum line. And once that is hard, you cannot brush it off. You can only brush off the soft material. That's why it's very important to get a thorough cleaning. But as I said, it's very important to know that you do not necessarily have to go to a specialist in gum disease and implants, a periodontist. So that's the good news. And it's very important then for the patient to maintain as good oral hygiene in between the dental visits as humanly possible. And you can also tell them that it's most important to brush really thoroughly just before bedtime, after you're done eating and drinking for the day, such that the accumulated dental plaque on the teeth cannot cause cavities and periodontal disease during the night when the saliva production is decreased and its cleansing and enamel remineralization actions are decreased. Cavities actually do not form in a straight line, if you will. The acid from the bacteria's metabolism in the dental plaque will break down the enamel, which consists mostly of chalk, of calcium, and that will break down with the acid. But luckily, the saliva has a very strong remineralizing effect, such that you can avoid getting real cavities. The effect on the gums are also much worse when there's no saliva to rinse away the plaque when it dries up. And that's why you have to brush really carefully in the evening.
Now, that's interesting, and I'm not sure everyone knows that, so that's very helpful. When we recommend brushing, there's a range of toothbrushes out there. There's soft, medium, hard bristles. Is there any that are particularly recommended over another?
Yeah, no, we all feel, I suppose, that we get a lot of action if we have some really stiff brush bristles and we brush forward and backward and scrub really well as if we were scrubbing a floor. However, that is going to do more harm than good. You could actually injure your gums, and you will not be able to get at the plaque that is at the borderline of the gum line, as we call it, the mucosa, the red meat, that, if you will, that you can see on the teeth. You have to use a really super soft toothbrush where the bristles are bendable and are thin enough so that you carefully can lodge them against the tooth and a little bit under the rim of the gum line, because that's where the dangerous bacteria are. So you would have to show patience, and you could only brush about 2 teeth at a time. So you place the toothbrush in a 45-degree angle if you can handle that, but at least so that the bristles point down in the little crevice between the teeth and the gums. And then you either circulate, rotate, or just move the brush back and forth a little bit, and then you just take 2 teeth at a time. It is most easy to brush when you have a lot of teeth because they are next to each other, like pearl on a necklace. However, if you have some gaps in between, it's very good to have a toothbrush that only has one little tuft at the end. Think pencil thickness, just with one little tuft, and then you can get around on the surfaces that are facing each other, but not the cheek or the tongue. And that's also very good. And the interior, in the backside of the teeth in the lower jaw, which is where the plaque and the tartar tend to accumulate most, simply because of gravity. When we are awake, we usually have our heads pointing in that direction with the nose up and the mouth down. And that's where it's really handy to have just a very small toothbrush. Alternatively, you can use the full-size brush, but tilted upwards, if you will, just so that the end of it can get to that area on the back of the lower incisors, as they are called, the front teeth in the middle.
So that's helpful to learn those things in that detail. Another question that comes up a lot is the role of flossing. Can you share your thoughts with that?
Flossing is wonderful. Great if you can do it properly, but you can actually do as much harm as good. Think of 2 teeth that are next to each other. They are a little bit conical in shape so that they have a contact point. What you want to have is the soft gums filling out the triangular surface or space under the contact point. If you can imagine just a room in there with nothing in it, it will very quickly be filled up with food remnants and bacteria. So you want to preserve your gums in between the teeth. And therefore, if you come with your floss and you yank it directly down from the contact point to the tip of that piece of meat, which is called the papilla, you can actually harm it, and so that it goes away and makes room for the impact, as it's called, impacting of food. So what you need to do is carefully get the floss down past the contact point, but following closely up against one tooth, and then back and forth a little bit under the gum line, then lift it up over the papilla, and then up against the other tooth next to it. And if it sounds complicated, it's because it is complicated. It's actually very difficult to do.
I was just thinking that. You're also making a very convincing argument for that original idea of making sure we remember to send someone to the dentist so the dentist and the dental hygienist can go over it in this detail.
Exactly. That is a very good reason to go to the dentist and to the dental hygienist, because especially the dental hygienist's job is to explain all these things and to clean the teeth and then educate the patient. Toothbrushing is really good, and the toothpaste should have fluoride in it, and it also contains some foaming agents and some good tasting agents, so that you feel that your mouth is fresh after you have brushed your teeth.
That's a good point. That's what I always like, that feeling of freshness, which is why I don't only brush before I go to bed, but sometimes I even brush before I go out. Which brings me to my next question that sometimes comes up in the office and I'm asked about, which is, what is the role of mouthwash?
Usually mouthwash contains between 17 and 21% alcohol. And I would say that it's much better if you drink alcohol, that it would be much better to have a whiskey on the rocks or something else in your mouth that contains so much alcohol. And the alcohol has two major effects that you do really not want. The one is that it dries out all your mucosa. A lot of your patients, I'm sure, suffer from dry mouth. So that's what you do not want. The other is that alcohol kills bacteria, good and bad. And you do not want to kill them all. You only want to kill the really bad ones. You want to keep the very delicate balance of the oral microbiome that consists of at least 700 species, maybe 1,000. Many of them we have not even begun to study yet. And that very delicate balance will then be interrupted if you come chasing them with your alcohol. However, I should mention that there are mouth rinses now on the market that do not contain alcohol. And so there are ways that you can rinse your mouth.
That's helpful.
Let me mention one little thing maybe that is very much unknown outside dentistry, is that it is not a good idea to brush your teeth first thing in the morning. Wait until after breakfast and after you have gotten your saliva production going, simply because when you are asleep and the saliva production is, the bacteria will still have demineralized some super thin layers of enamel. So if you scrub that little bit of soft enamel away, you can end up with sensitive teeth. So it's better to go about your business and have your breakfast and then brush.
Fascinating. I had never heard that. Now, we've covered a lot of things that we in primary care and endocrinology can talk to our patients about. Is there anything else that is important for us to think about that we didn't cover as we just discussed things?
I would like to mention that the American Diabetes Association does recommend the initial dental checkup in their guidelines that come out every January, but it doesn't have a prominent place.
Yeah, they do. They certainly say in the standards of care upon diagnosis you should see dentistry. And as I've been listening to you discuss the importance, Wenche, it makes me think when I'm talking to patients that teeth are in many ways a foreign area for many of us as physicians, that we make sure that they get referred for optimal oral health on a regular basis. Just to be clear, that's not in the standards of care. This is what I'm taking away from our discussion as something that seems pretty clearly would be helping our patients.
If I may add one little thing that has helped me over the years, and in trying to figure out which patients you should especially encourage to go to the dentist, there's a whole body of literature that tests and validates questions that are well correlated with the clinical situation. Simple questions like, do you have any trouble with your teeth or your gums? Do you have any teeth that are loose? You can ask, do you have trouble chewing your food? Do you think you might have gum disease? That's actually very closely related to having gum disease, especially severe disease. Another one would be, do your gums bleed when you brush your teeth? Which they should not, right? If they are not inflamed. And then an interesting question is, during the last 3 months, have you noticed a tooth that does not look right? And we can discuss what that means, but sometimes it's because it looks longer, because the gums have retracted because of gum disease, or it can be that it has tilted or twisted or something else. So that is actually a very good indicator. And the dangerous thing with periodontitis is that it may not necessarily give you any symptoms until the tooth is loose. And that's when it's very difficult to salvage a tooth. So that's why you need to go to a dentist or a hygienist who will measure how deep the space is, the pocket is it called, between the tooth and the gums. It's supposed to be a millimeter. Up to 3 is acceptable, but then we start to see severe disease. And some of the signs and symptoms could be bleeding, as we just discussed. It could be a little bit of pain or tingling in the gums, and the retraction of the gum line, like I just said, so the tooth looks longer. And it could be a foul taste or smell from the pus, but that's very advanced.
That makes sense. Now, all of good dental care costs a lot. We live in an age where people are very attentive to cost. Can you discuss whether it's cost effective for people with diabetes? And that's my understanding, that when you take into account the cost of both the direct oral consequences as well as other systemic diseases, that it is a cost-effective intervention for health. Mm-hmm. Is that correct?
Yeah. And there is now a mounting body of evidence for the fact that receiving dental treatment, especially periodontal treatment and extractions of really seriously affected teeth, have a positive effect on medical expenses in patients with diabetes, both for the treatment of the diabetes itself, but also for all the other diseases that people with diabetes typically have and the complications of diabetes. It certainly is very cost effective from a financial standpoint. Then we also have other costs in terms of pain and discomfort and so forth that are difficult to measure. But for sure, the financial cost can be certainly cost effective, whatever you invest in the teeth.
And that prompts my last question when you mentioned pain and how people feel. And can you talk a little bit about how good dental care affects quality of life?
People with good dental care, dental health, seem to be enjoying life much better. When you compare to people who have dirty teeth, who have missing teeth, who have teeth that are affected by a caries, by cavities that you can see, because the latter group will often feel handicapped and terribly embarrassed that they did not manage to keep their teeth, keep them at all, or keep them in good shape. And removable dentures can sometimes simply fall down. The nightmare for many people would be if they have a full upper denture that if they laugh a lot, it would simply fall down. So a lot of people will not wish to eat in public at a restaurant, or they will simply not even go out of their house to meet other people, or they will eat or smile and cover their mouth. So it's a very much a decreased quality of life you live, plus of course all the pain and discomfort associated with not being able to eat, especially all the healthy food that you are trying to get them to eat, because they simply cannot, because they're either missing teeth or some teeth are loose or loosened, such that they will hurt a lot when you try to chew or bite with them.
Yeah, I know for many of my older patients, this becomes a critical issue with regard to getting in sufficient nutrition, because nutrition usually starts at the mouth, and it can present some very real challenges, particularly as people get older. We're about out of time. We've covered a lot of ground. Any last thoughts, bring things together for our listeners?
Yeah, my huge hope is that these two podcasts have helped make medical clinicians aware of the very important role of the oral cavity, and I hope that you will see this as yet another tool in your toolbox for trying to manage together with your patient their disease. And please don't hesitate to look in the mouth. You know what inflammation looks like, and you can actually sometimes smell inflammation, which is different from bad breath from eating garlic or something like that. Lastly, I'd like to mention my short article that is publicly available, Current Scientific Evidence for Why Periodontitis Should Be Included in Diabetes Management. It was published earlier this year and consists of only 2,000 words and a detailed illustration of the mechanisms that underlie these bidirectional effects between periodontitis and diabetes, but it cites 215 articles, so it's an easy, quick read, but provides plenty of references for those who want more detail.
Thank you. I can tell you, you've convinced me to be talking a lot more regularly than I have been about oral health with my patients. I think all of us who have listened to you talk today have learned a lot. Dr. Wenche Borgnakke, thank you so much for joining us.
Oh, thank you again for having me, Neil.
Thank you. I have learned so much: to brush at night, to use a soft bristle brush, to be far more careful when flossing than I am used to being with flossing. To our listeners, thank you for joining us on this second of our two-part series on oral health. These two special editions of Diabetes Core Update focused on oral health are sponsored by Haleon, the makers of Periodontics. Let me again share a message from our sponsor. Patients with type 2 diabetes are more likely to have gum disease, cavities, and other oral health problems. Periodontics is a daily use toothpaste that is clinically proven with twice daily brushing to reverse and prevent gingivitis, an early form of gum disease. Visit HaleonHealthPartner.com to learn more about the Periodontics portfolio of oral health products and how they can support your patients' gum health. We at ADA are appreciative of Haleon sponsoring this important topic. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.